Welcome to the January 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the January issues of the journal, as well as commentaries by Dr. Frank A. Cordasco on the article entitled Return to Function, Complication, and Reoperation Rates Following Primary Pectoralis Major Tendon Repair in Military Service Members, and Dr. James A. Shaw on the article entitled Low-Dose Aspirin is Effective Chemoprophylaxis Against Clinically Important Venous Thromboembolism Following Total Joint Arthroplasty, a Preliminary Analysis. Be sure to check out this month's Current Concepts Review article on the ulnar collateral ligament injury, evaluation and treatment by Drs. Brandon J. Erickson and Anthony A. Romeo. Ulnar collateral ligament UCL injuries are increasing in high school, collegiate, and professional athletes. The initial treatment following a UCL tear involves a period of rest followed by rehabilitation and a graduated throwing program. UCL reconstruction, UCLR, has become the preferred surgical treatment method for patients with a symptomatic deficient UCL who wish to return to sports. Several modifications to the original technique described by Jobe et al. Have been proposed, including a muscle-splitting approach, a docking technique, and the use of various grafts. The timing of return to sport following UCLR varies from patient to patient, with some patients being able to return within 12 months and others taking greater than 18 months. Although the literature varies, typically greater than 80% of the patients are able to return to the same level of sport following UCLR. In this issue, JBJS.org presents a new image quiz, a 44-year-old man with knee pain without injury. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Return to Function, Complication, and Reoperation Rates Following Primary Pectoralis Major Tendon Repair in Military Service Members by Dr. Drew W. Newt and Associates. Investigation performed at the Department of Orthopedic Surgery and Rehabilitation, William Beaumont Army Medical Center, El Paso, Texas. Pectoralis major tendon ruptures have become increasingly common injuries among young, active individuals over the past 30 years. However, there is presently a paucity of reported outcome data. The authors investigated the ability to return to full preoperative level of function, complications, reoperation rates, and risk factors for failure following surgical repair of the pectoralis major tendon in a cohort of young, highly active individuals. All U.S. active-duty military patients undergoing pectoralis major tendon repair between 2008 and 2013 were identified from the military health system using the Management Analysis and Reporting Tool, M2. Demographic characteristics, injury characteristics, and trends in preoperative and postoperative self-reported pain scale and strength were extracted. The ability to return to the full preoperative level of function and rates of re-rupture and reoperation were the primary outcome measures. Univariate analysis, followed by multivariate analysis, identified significant variables. A total of 257 patients with pectoralis major tendon repair were identified with a mean follow-up of 47.8 plus or minus 17 months. At the time of the latest follow-up, 242 patients were able to return to the full preoperative level of military function. 15 patients were unable to return to duty because of persistent upper extremity disability. A total of 15 re-ruptures occurred in 14 patients. Increasing body mass index and active psychiatric conditions were significant predictors of inability to return to function and total failure. Conclusions. The authors demonstrate that 94% of patients were able to return to the full preoperative level of function within active military duty following surgical repair of pectoralis major tendon rupture, and 5.4% of patients experienced re-rupture after primary repair. Increasing body mass index and active psychiatric diagnoses are significant risk factors for an inability to return to function and postoperative failures. Next, you'll hear a commentary by Dr. Frank A. Cordasco on the article entitled Return to Function, Complication, and Reoperation Rates Following Primary Pectoralis Major Tendon Repair in Military Service Members.
This is Dr. Frank A. Cordasco, providing commentary for the January 2017 JBJS podcast. I will be providing commentary on the article entitled Return to Function, Complication, and Reoperation Rates Following Primary Pectoralis Major Tendon Repair in military service members. The title of my commentary is Outcomes of Pectoralis Major Tendon Repair. Does study design matter? Newt et al. Are to be congratulated for this retrospective study comprising a large cohort of 257 U.S. active duty military patients following primary pectoralis major tendon repair, performed by 152 surgeons at 57 medical treatment facilities between 2008 and 2013, with a minimum follow-up of 2 years. The patients were identified from the military health system utilizing the Management Analysis and Reporting tool. Historically, pectoralis major tendon tears have occurred infrequently. A systematic review identified only 365 cases in the literature since Petitier's first description of the injury in 1822 through the year 2010. Pectoralis major tendon tears have occurred with increasing frequency in more recent years. Changing demographic characteristics with increased participation in contact sports and weight training activities are likely responsible. Previous studies have demonstrated that improved outcomes can be anticipated with surgical repair compared with non-operative treatment, and that acute repair is preferable. Recent publications have begun to provide more information on anticipated functional outcomes, adduction strength following surgical repair, complications, and second surgical procedure rates. The strengths of this study from Newt et al. Include the large cohort of patients and the information provided with regard to functional outcomes, complications, reoperation rates, and risk factors for failure. A total of 242 patients were able to return to full duty at a mean time of 7.1 months following the surgical procedure. Despite excellent functional outcomes, the authors note atypically high surgical site morbidity with an overall complication rate of 23%. 41 major complications occurred in 31 patients, and these included re-rupture following repair and wound complications requiring a return to the operating room. Altogether, 21 patients required 29 additional surgical procedures. 15 re-ruptures occurred in 14 patients, and 8 of these patients underwent revision repair. 13 of these patients required 21 surgical procedures for wound complications, including infection. Although the cohort is large, so are the numbers of surgeons and medical treatment facilities. The authors have not presented the number of cases per surgeon, and it is likely that few surgeons in this study treated a high volume of patients. This is an additional strength of the study in that it may represent the outcome that a surgeon can expect in a setting in which few cases are performed per year. This also represents one of the weaknesses of the study. Surgical volume has clearly been associated with better outcomes and fewer complications. Newt et al. Acknowledge the additional weaknesses which are related to the inherent limitations of healthcare management databases with data pooled from multiple surgeons across multiple medical centers. These weaknesses include that the surgical approach could not be determined in many of the cases because it was inconsistently reported, and as a result, the relatively high infection and wound complication rates could not be correlated with the approach selected by the individual surgeons. It lacks a quantitative assessment of strength and function using handheld dynamometers, isokinetic testing, or bench press data, which would be more rigorous than the Medical Research Council muscle strength grading scale. The data were inconclusive with respect to acute compared with chronic repair outcomes, and quantitative measures of adiposity, which would be more thorough to consider with respect to body mass index, were not evaluated. This study has several similarities to another recent publication that identified 291 patients with pectoralis major tendon repairs in an active duty military population. Balaz et al. Utilized a similar military database to identify all active duty personnel who were surgically treated by multiple surgeons at multiple facilities between 2012 and 2014. The database was mined to obtain demographic information, injury characteristics, and postoperative complications and outcomes. The authors concluded that white race and a surgical procedure occurring greater than 6 weeks from injury were significant risk factors for a complication. Among the 214 patients with a minimum follow-up of 12 months, 95.3% were able to return to military duty, and junior personnel were at the highest risk of being unable to return to duty after surgical treatment. Those two large healthcare management database studies added a total of 548 patients following pectoralis major tendon repair to the world literature. The relatively high complication and second surgical procedure rates described above can be compared with those of two of the larger single-surgeon series. Garrigues et al. Performed a retrospective study of 24 patients with pectoralis major tendon repair between 2005 and 2011. Using the Bach criteria, the results for 96% of the patients were rated good to excellent. The mean preoperative bench press of 318 pounds was restored to 264 pounds at the time of follow-up. There were no incidents of a second surgical procedure or postoperative wound complications. Our group has reported on a consecutive series of 40 athletes with pectoralis major tendon repair at minimum 2-year follow-up among a larger cohort of 82 athletes treated between 2008 and 2016. The repairs were performed using a previously published surgical technique. The mean postoperative single assessment numeric evaluation score was 93.6 points, and patient satisfaction was 9.6 of 10. All athletes returned to the pre-injury level of function approximately 5.5 months postoperatively. Isokinetic strength evaluation revealed an average decrease of less than 10%. The mean pre-injury bench press of 396 pounds was restored to 241 pounds postoperatively. 3 athletes required a second surgical procedure. 2 had re-ruptures within 3 weeks of the surgical procedure, secondary to non-compliance and trauma. Excluding these 2, there were no re-ruptures, and the second surgical procedure rate would be 2.5%. There were no postoperative wound complications or infections among the entire cohort of 82 athletes. We also identified a relationship between tear type and tear location. That finding had implications with regard to preoperative imaging and indications for a surgical procedure. It might not have been recognized if not for careful observation at the time of the surgical procedure, and might have been missed in a large database-generated study. Both meta-analyses and healthcare management databases with data pooled from multiple surgeons and medical centers, as well as single-surgeon high-volume studies, have merit for different reasons and may be used to inform decision-making by patients, practicing surgeons, and entities responsible for the delivery of services.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled, Preoperative Opioid Use is Associated with Early Revision After Total Knee Arthroplasty, a study of male patients treated in the Veterans Affairs System by Dr. Alon Ben-Ari and Associates. Investigation performed at the Department of Anesthesiology and Pain Medicine and Department of Orthopedic Surgery and Sports Medicine, VA Puget Sound Healthcare System, University of Washington, Seattle, Washington. Opioid use is endemic in the U.S. and is associated with morbidity and mortality. The impact of long-term opioid use on joint replacement outcomes remains unknown. The authors tested the hypothesis that use of opioids is associated with adverse outcomes after total knee arthroplasty, TKA. The authors performed a retrospective analysis of patients who had had TKA within the U.S. Veterans Affairs VA system over a 6-year period and had been followed for 1 year postoperatively. The length of time for which an opioid had been prescribed and the morphine equivalent dose were calculated for each patient. Patients for whom opioids had been prescribed for greater than 3 months in the year prior to the TKA were assigned to the long-term opioid group. A natural language processing-based machine learning classifier was developed to classify revisions due to infectious and non-infectious causes on the basis of the postoperative note. Survival curves for the time to knee revision or manipulation were used to compare the long-term opioid group with the patients who did not take opioids long-term. Hazard and odds ratios for knee revision and manipulation were obtained as well. Of 32,636 patients who underwent TKA, 12,772, 39.1%, were in the long-term opioid group, and 734 had a revision within 1 year after the TKA. Chronic kidney disease, diabetes, and long-term opioid use were associated with revision within 1 year, with odds ratios of 1.76, 1.11, and 1.40 respectively, and were also the leading factors associated with a revision at any time after the index TKA, with odds ratios of 1.61, 1.21, and 1.28 respectively. Long-term opioid use had a hazard ratio of 1.19 in the analysis of its relationship with knee revision, but the hazard was not significant in the analysis of its association with knee manipulation. The accuracy of the text classifier was 0.94, with the area under the receiver operating characteristic curve being 0.99. There was no association between long-term use of opioids and the specific cause for knee revision. Conclusions. Long-term opioid use prior to TKA was associated with an increased risk of knee revision during the first year after TKA among predominantly male patients treated in the VA system. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Low-Dose Aspirin is Effective Chemoprophylaxis Against Clinically Important Venous Thromboembolism Following Total Joint Arthroplasty, a preliminary analysis by Dr. Javad Parvizi and Associates. Investigation performed at the Rothman Institute at Thomas Jefferson University Hospital, Philadelphia, Pennsylvania. Aspirin is a safe and effective prophylaxis for the prevention of venous thromboembolism following total joint arthroplasty. The optimal dose of aspirin prophylaxis is unknown. The author's hypothesis was that lower-dose aspirin is as effective as higher-dose aspirin for the prevention of venous thromboembolism and is associated with fewer gastrointestinal side effects. In a prospective crossover study, the authors analyzed 4,651 primary total joint arthroplasty cases performed from July 2013 to June 2015. For 4 weeks, 3,192 patients received enteric-coated 325 mg aspirin twice daily, and 1,459 patients received 81 mg aspirin twice daily. There were no significant differences in sex, body mass index, or Charlson comorbidity index between the 2 patient populations. Recorded complications occurring within 90 days postoperatively included symptomatic venous thromboembolism, gastrointestinal complications, acute periprosthetic joint infection, and death. The incidence of venous thromboembolism of 0.1% in the 81 mg aspirin group was not significantly different from 0.3% in the 325 mg aspirin group. The incidence of gastrointestinal bleeding or ulceration of 0.3% in the 81 mg aspirin group was slightly but not significantly lower than the 0.4% in the 325 mg aspirin group. The incidence of acute periprosthetic joint infection was 0.2% in the 81 mg aspirin group compared with 0.5% in the 325 mg aspirin group. The 90-day mortality rate was similar in both groups at 0.1% in the 81 mg aspirin group and 0.1% in the 325 mg aspirin group. Conclusions. This study demonstrates that low-dose aspirin is not inferior to high-dose aspirin for venous thromboembolism prophylaxis following total joint arthroplasty. This is not unexpected, as the available literature demonstrates that low-dose aspirin is as effective as higher-dose aspirin in the prevention of acute coronary syndrome and cerebrovascular events. Next, you'll hear a commentary by Dr. James A. Shaw on the article entitled Low-Dose Aspirin is Effective Chemoprophylaxis Against Clinically Important Venous Thromboembolism Following Total Joint Arthroplasty, a Preliminary Analysis.
This is Dr. James A. Shaw providing commentary for the January JBJS podcast. I will be providing commentary on an article entitled Low-Dose Aspirin is Effective Chemoprophylaxis Against Clinically Important Venous Thromboembolism Following Total Joint Arthroplasty, a Preliminary Analysis. The title of my commentary is Aspirin, the unsung champion of deep venous thrombosis chemoprophylaxis, a historical perspective. Aspirin chemoprophylaxis for thromboembolic events following total joint arthroplasty was introduced by Harris and other researchers in the late 1970s. It was an era when patients who underwent hip replacement were typically bedbound in balanced suspension for a week or more following the surgical procedure, and patients who underwent knee replacement were similarly managed, except for a Jones wrap and long leg splints replacing the balanced suspension. Deep venous thrombosis and pulmonary embolus were a pall overshadowing total joint arthroplasty, and any glimmer of hope with regard to these dreaded complications was welcomed by the orthopedic community. Low molecular weight dextran and low-dose heparin, among other modalities, underwent trials with variable clinical success. Perhaps more than anyone, Dr. Paul Lockey championed the use of aspirin throughout the 1980s and 1990s with clinical and venographic data showing efficacy in both men and women. Over time, chemoprophylaxis evolved. Warfarin was found to have superior efficacy to other modalities in most studies and became the standard of practice in the 1980s. However, it was difficult to administer, with a wide range of patient sensitivities to the drug, requiring diligent and time-consuming laboratory monitoring. Underdosing and overdosing was problematic. In the 1990s, low molecular weight heparins were introduced, which simplified administration but carried a somewhat greater risk of wound bleeding and drainage, well documented to be a contributing factor to deep wound infection. At the same time, arthroplasty and patient management evolved. Surgical procedure times and surgical approaches were improved dramatically. Epidural and spinal anesthesias were selected preferentially for most patients based, in part, on the theoretical advantage of increased peripheral blood flow and a corresponding decrease in venous stasis. Pneumatic calf, thigh, and foot pumps were introduced. Active patient ankle pumping and quadriceps sets were encouraged when in bed or chair. Perhaps most importantly, patients were mobilized earlier. Most were out of bed and were sent to physical therapy on postoperative day 1, or even the day of the surgical procedure in some centers. With these ancillary modifications, the entire specter of venous disease seemed to change, with a dramatic reduction in the frequency of clinically apparent deep venous thrombosis and fatal pulmonary embolism. With such a low incidence, it became difficult to distinguish differences in efficacy on a statistical basis between the different chemoprophylactic modalities, including the use of aspirin, particularly if used in conjunction with mechanical devices. As such, aspirin's use as a chemoprophylaxis agent was revitalized. It was inexpensive, required no monitoring, was easily administered on an outpatient basis, carried little associated bleeding risk, and demonstrated equivalent efficacy. Basically, it was a no-brainer in the minds of many arthroplasty surgeons, and eventually it was formally endorsed in 2007 by the American Academy of Orthopedic Surgeons in normal risk patients, with subsequent updates to maintain inclusion in the National Guideline Clearinghouse of the Agency for Healthcare Research and Quality. The only downside appeared to be a small risk of gastrointestinal bleeding and a rare allergic reaction. The only remaining question was the dose. If a regimen of 325 milligrams twice a day was efficacious, perhaps a smaller dose would be equivalently efficacious with less risk of complications. Parvizi et al. Found no significant difference in efficacy or complications when comparing the two regimens, but there was a suggestion of a smaller risk of gastrointestinal bleeding with the lower dose. So in summary, if selecting aspirin as a chemoprophylactic agent, the dose appears to be the surgeon's choice, with a non-significant difference in the incidence of gastrointestinal bleeding seemingly favoring the lower dose. As a point of caution, however, The article by Parvizi et al., like many others, defines efficacy only in terms of clinically important events, determined by physical examination, which is notoriously inaccurate, and patient symptoms, which may be ignored, underreported, or not present. However, we are treating patients, not radiographic or ultrasound findings, so clinically important events are a reasonable benchmark.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Characterizing the Propionibacterium Load in Revision Shoulder Arthroplasty, a study of 137 culture-positive cases by Dr. Zahab S. Hassan and Associates. Investigation performed at the Department of Orthopedics and Sports Medicine, University of Washington, Seattle, Washington. Propionibacterium is commonly recovered from explants or surrounding tissues in revision shoulder arthroplasty. Rather than attempting to differentiate a true infection from a false positive result on the basis of the number of positive cultures, the authors characterized the amount of these bacteria in each specimen and shoulder. The study included 137 revision shoulder arthroplasties, from which a minimum of 4 specimens had been submitted for culture, and at least 1 was positive for Propionibacterium. Standard microbiology procedures were used to assign a semi-quantitative value called the specimen propy value to the amount of growth in each specimen. The sum of the specimen propy values for each shoulder was defined as the shoulder propy score, which was then divided by the total number of specimens to calculate the average shoulder propy score. The number and percentage of positive specimen-specific cultures of material obtained from the stem explant, head explant, glenoid explant, humeral membrane, collar membrane, other soft tissue, fluid or other, per shoulder range from 1 to 6 and 14% to 100%. A high percentage of specimens from culture-positive shoulders showed no growth. Only 32.6% of the fluid cultures were positive, in comparison with 66.5% of the soft tissue cultures and 55.6% of the cultures of explant specimens. The average specimen propy value for fluid specimens was significantly lower than those for the soft tissue and explant specimens. The shoulder propy score was significantly higher in men than in women. Similarly, men had a significantly higher average shoulder propy score than women. Conclusions. This investigation suggests that Propionibacterium is unevenly distributed within culture-positive revised shoulders. As a result, the specimen number and source explants, soft tissue or fluid, have major influences on the culture results for a revised shoulder arthroplasty. The authors found no evidence that suggested useful threshold values for defining a true infection. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.